Anger is a normal human emotion. It's a strong, uncomfortable emotional response to a real or a perceived provocation. It results when a person is frustrated, hurt, or afraid. It activates the fight or flight response in the sympathetic nervous system and energizes the body for self-defense. It can be a positive force that helps a person solve problems and make decisions when it's handled appropriately. It can also cause physical and emotional problems and interfere with relationships when handled inappropriately or when it's suppressed. Hostility is also referred to as verbal aggression. It's expressed through verbal abuse, lack of cooperation, violating rules or norms, or threatening behavior. Hostile behavior is intended to intimidate or cause emotional harm and can lead to physical aggression. Physical aggression is behavior in which a person attacks or injures another person or involves the destruction of physical property. Some patients with psychiatric disorders display hostile or physically aggressive behavior, and that can be a challenge for staff. Catharsis is activities that are supposed to provide a release for anger, like hitting a punching bag or yelling. Sometimes, however, catharsis can increase the feelings of anger rather than release them. Walking, talking to someone, distraction, problem solving, or reframing may be better activities to decrease anger. High hostility and anger have been associated with an increased risk for coronary artery disease and hypertension. Suppressing anger or trying to ignore angry feelings can adversely affect the control of hypertension. Women are more likely than men to suppress their anger. Hostile and aggressive behavior can be sudden and unexpected. Stages in the aggression cycle are the triggering phase, which is the incident that initiates an aggressive response, escalation phase, crisis phase, recovery phase, and post-crisis phase. As a patient moves into the crisis phase, they lose the ability to perceive events accurately, solve problems, express feelings appropriately, or to control their behavior. Behavior escalation can lead to physical aggression, so interventions during the triggering and escalation phases are key to preventing physical and aggressive behavior. The media pays a lot of attention to people with a mental illness who commit aggressive acts. There are lots of examples out there. This gives the general public the mistaken idea that most people with mental illnesses are aggressive and should be feared. In reality, those with a mental disorder are more likely to hurt themselves than they are to hurt anyone else. Some people with a variety of mental illnesses can have angry, hostile, or aggressive behavior. Those with paranoid delusions may think someone is out to get them and may act out aggressively thinking that they're protecting themselves. Some patients may have command auditory hallucinations that tell them to hurt others. Those with dementia, delirium, head injuries, substance abuse issues, antisocial or borderline personality may also act out with aggression. Depressed patients may have anger attacks, which are sudden, intense spells of anger that occur in situations that cause the person to feel trapped. Intermittent explosive disorder is characterized by episodes of aggressive impulses that result in serious attacks or the destruction of property. The aggressive response is disproportionate to the provocation. Acting out is an immature defense mechanism. It's how the person deals with emotional conflicts or stressors, using actions rather than talking about their feelings. It can be displayed as verbal or physical aggression when the person feels helpless or powerless. Children or adolescents may act out when they can't handle their intense feelings or emotional conflict. Researchers have looked at the role of neurotransmitters in aggression in both animals and humans, but have not found a cause. Serotonin plays an inhibitory role in aggressive behavior, so those with low serotonin may have increased aggression, which may explain why those with depression can have anger attacks. Increased activity of dopamine or norepinephrine have been associated with increased impulsively violent behavior. Structural damage to the limbic system and the frontal and temporal lobes of the brain can also modulate aggression, which can lead to aggressive behavior. As a child matures, they're expected to develop impulse control, or the ability to delay gratification. If a child comes from a dysfunctional family and does not have positive relationships with parents, teachers, and peers, they may not develop this skill, but may be impulsive, easily frustrated, and prone to aggressive behavior. Culture influences how anger is expressed. In the United States, women were not permitted to express anger, or they would or they would not be seen as feminine. This has changed in the past 25 years or so. For Asians and Native Americans, expressing anger is seen as being rude or disrespectful, and it should be avoided at all costs. Ethnic or minority status can have a role in the diagnosis and treatment of psychiatric illnesses. People with darker skin can be seen as being more dangerous than their light-skinned counterparts, so they are more likely to have compulsory hospitalizations, increased use of restraints, and higher doses of medication. Hwang is a culture-bound syndrome that literally translates as anger syndrome or fire illness. It's attributed to anger suppression, and it's seen in Korea, usually in women who experience sighing, abdominal pain, insomnia, irritability, anxiety, and depression. Buffet-Delirant is another culture-bound syndrome, this one found in West Africa or Haiti. It's characterized by a sudden outburst of agitated or aggressive behavior, marked confusion, and psychomotor excitement. Those experiencing it may also have visual and auditory hallucinations or paranoid ideation. Amok is a dissociative episode that's followed by a period of brooding, followed by an outburst of violent, aggressive, or homicidal behavior directed at other people or an object. It originally came from Malaysia, but has also been seen in Laos, the Philippines, Papua New Guinea, Polynesia, Puerto Rico, and among the Navajo. Amok is only seen in men. Treatment of aggression usually focuses on treating the underlying psychiatric diagnosis, like schizophrenia or bipolar. Lithium has been successful treating aggressive patients with bipolar disorder, childhood conduct disorders, and mental retardation. Carbamazepine or Depakote, which is valproic acid, are used to treat aggression associated with dementia, psychosis, and personality disorders. Atypical antipsychotics like clozapine, risperidone, and olanzapine are used to treat aggression in people with dementia, brain injury, mental retardation, and personality disorders. Benzodiazepines can reduce irritability and agitation in older adults, but they can result in the loss of social inhibition for other patients, making them more aggressive rather than less. Haloperidol and lorazepam are usually used together to decrease agitation, aggression, or psychotic symptoms. Sometimes you'll hear it referred to as vitamin B52, which is Benadryl 50, Haldol 5, and Ativan 2. Atypical antipsychotics are more effective for aggressive patients than conventional, like olanzapine or ziprasidone. Using antipsychotics requires careful observation for the development of extrapyramidal symptoms, or EPS, which can be treated with benztropine or cogentin. Assessment and effective interventions with angry or aggressive patients can usually prevent aggressive episodes. Early assessment, judicious use of medications, and verbal interaction with an angry patient can frequently prevent anger from becoming physical aggression. The nurse should be aware of factors that influence aggression in the milieu. Aggressive behavior is less common when there's strong psychiatric leadership, clear staff roles, and planned and adequate events such as staff-patient interaction, group interactions, and activities. Schedules are very important in psychiatric care. When the schedules get off, patients may feel frustrated and bored, and aggression is more common and intense. Having no privacy and not getting adequate rest can trigger aggression as well. In addition to assessing the milieu, the nurse also needs to assess each patient individually. A history of violent or aggressive behavior is the best predictor of future aggression. A history of being victimized, one of substance abuse, or those who believe their hallucinations are all-powerful can also increase the likelihood of aggressive behavior. Some cues can be what the patient is saying, changes in the patient's voice, like the volume, pitch, speed, changes in their facial expressions, and changes in their behaviors. Some common diagnoses for patients with aggression include risk for other directed violence and ineffective coping. Expected outcomes for the patient may include the patient will not harm themselves or others, the patient will refrain from behaviors that are intimidating or frightening to others, the patient will describe their feelings and concerns without aggression, or the patient will comply with treatment. Interventions are most effective and least restrictive when they are implemented early in the aggression cycle. Some ways to manage the environment include groups and planned activities, like playing cards, watching a movie, or having an informal discussion. These give the patients the opportunity to talk about events or issues while they're calm. They also engage the patients in the therapeutic process and minimize boredom. One-to-one interactions between staff and patient shows genuine interest and a willingness to listen. Problem solving or conflict resolution allows patients to express anger appropriately and gives them an opportunity to practice skills of assertive communication and negotiating a solution. The safety of other patients need to be managed when one is psychotic, hyperactive, or intoxicated. Talking to the other patients can be helpful, and supervise the patient who's potentially aggressive very closely. During the triggering phase, the nurse should approach the patient in a calm, non-threatening manner and try to de-escalate the situation, conveying empathy and allowing the patient to voice their frustrations. Give the patient time to express themselves and use short, clear statements when talking to them. At this point, the patient still has control of themselves. A quiet area, PRN medications, or pacing may all be helpful in helping the patient to calm down. In the escalation phase, the nurse needs to take control of the situation. Give directions to the patient in a calm, firm voice. The patient will need a quiet area like a quiet room or their room to help them regain control. Medications can be offered again if they were refused before. Let the patient know that aggressive behavior is not okay and the nurse is there to help them calm down and regain control. If the patient isn't able to calm down or they refuse to be redirected to a quiet area, the nurse may need to get assistance from additional staff members. A show of force is some additional staff members who come up to the unit. Is typically about 4 to 6, and they should be inside of the patient, but not as close as the nurse who's talking to the patient. Having additional people there sometimes convinces the patient to do what they're asked without actually using additional force. In the crisis phase, the patient is out of control and is physically aggressive. Staff must take over at this point for the safety of everyone on the unit. Psychiatric facilities have training and practice safe techniques to manage these situations. Only trained staff should participate in restraining someone who's physically aggressive. The nurse decides if restraint or seclusion are necessary and must get a doctor's order as soon as possible once the situation is safe. If medication was not given earlier, it should be given now. As the patient regains control, they're encouraged to talk about the situation and to reflect on what happened. The nurse should help the patient relax, hopefully sleep, and calm down. Explore alternatives to the aggressive behavior with the patient to avoid a repeat of an aggressive episode. Assess the patient and staff for any injuries and document them if they occurred. Staff has a debriefing session where they discuss what happened, how it was handled, what they can change, and how they can try to prevent it from happening again. During the post-crisis phase, the patient is released from restraint or seclusion once they meet the criteria. The nurse should discuss the behavior with the patient in a calm manner, without lecturing or chastising. Alternatives to the behavior can be discussed with feedback on regaining control. Focus on the appropriate expression of feelings and resolving conflict in a non-aggressive manner. The patient can then rejoin the milieu and go to groups and participate in activities. Care is most effective when anger can be defused at an early stage, but restraint and seclusion are sometimes necessary. The goal is to teach angry, hostile, and physically aggressive patients to express their feelings verbally without threatening or harming anyone or any property. In July 2008, the Joint Commission issued a Sentinel Event Alert about intimidating and disrupting behaviors that undermine a culture of safety and lead to errors, decreased patient satisfaction, preventable adverse outcomes, increased healthcare costs, and loss of qualified personnel. These undesirable behaviors include overt actions like verbal outbursts and physical threats, along with passive actions like refusing to do assigned tasks or having an uncooperative attitude. The Joint Commission issued new standards of leadership in January of 2009. Any accredited healthcare organization must have a code of conduct that defines acceptable and disruptive and inappropriate behaviors. Leaders also have to create and implement a process for managing disruptive and inappropriate behaviors. Several action steps have been suggested. A code of conduct that outlines acceptable and inappropriate or unacceptable behavior. A process for managers to handle disruptive or unacceptable behavior. Education of all team members on expected professional behavior. And a zero tolerance for unacceptable behaviors, meaning that all people are held accountable. For many people with aggressive behavior, effective management of the comorbid psychiatric disorder is key to controlling aggression. Regular follow-up appointments, compliance with prescribed medications, and participation in community support programs all help the person to achieve stability. The Forensic Early Warning Signs of Aggression Inventory is a screening tool for nurses and patients in identifying and monitoring early warning signs of aggression. There are 44 early signs that are subdivided into 15 categories. The hope is to prevent aggressive behavior. Anger management groups are available to help patients express their feelings and learn problem-solving and conflict resolution techniques. The nurse needs to be aware of how they deal with anger before helping patients to do so. If the nurse is afraid of angry feelings, they may avoid a patient's anger, which allows the behavior to escalate. If the nurse responds in anger, it can also cause behavior to escalate. Remember not to take someone else's anger or aggression personally, and it's not a measure of your effectiveness as a nurse. There's always a risk of injury when a patient is aggressive. Ongoing education and practice of safe techniques are essential to minimize the risk of injury to staff and patient. The nurse must remain calm, non-judgmental, and be non-punitive.